cases which may then we will go in cases which may be seen in your practice, daily activity, daily work, daily on calls, um, starting from case by case, like pericardial tamponade, total anomalous, ductal dependent lesion, complete heart block, device retrieval, trauma, alcaba, all of these. The idea of talk is not to go in clinical review rather than brainstorming, chatting between fellows between and us between surgeon and cardiologist during those life-threatening events. So as we know that the cardiac life-threatening events developed in the neonate and infant usually are fatal and complex. Unfortunately, because the new experience and developing knowledge in our field, our mortality is dropped down, and most of these cardiac defects become treatable. This is one point. This is the positive things. But the bad things, on the other hands, those patients will survive to the adulthood and they will develop and they will expose to another life-threatening events in another form. So the pattern of exposure will change from nowadays in 20 to after 2025 in compared to before 2 3 decades. Other point to be mentioned here that the prognosis is also changed. The prognosis for those events become good, favorable, because we recognize it quickly and manage it aggressively. That's why we are talking today about communication between us. This is the list of the most common events which you may see it in your uh, meeting and in your life, in your practice. You may communicate with surgeon, you as a cardiologist, or me with you as a surgeon. When we have a procedure related complication like device migration, dissection, uh, perforation, retrieving of the device, or I have a shunt that was blocked and I need cardiology intervention and help, or I have a case of trauma that's shared between you and me and you, or you have a cardiac tamponade, I have a cardiac emergencies like a total anomalous pulmonary venous drainage, or I have a structural defect, either cyanotic of low cardiac output with the left side lesion, right side lesion, obstructive lesion, or I have a case with complete heart block that she need to be tackled early with basing, or sometimes you will exposed to acquired disease rheumatic with its complication, infective endocarditis with its life-threatening complications, um, viral infection with myocardial dysfunction. All of these we will see it in your life. The most important is a communication, is a knowledgeable communication, one by one. Simple things to start with. Let's to say that they call you and they said to you, hello, you have a patient in ER. They throw the patient with the suspected pericardial effusion. This is a 6 years old patient. He came to the ER after 2 weeks of post-ops, and you see the X-ray is very clear. Post-op patient with huge chest. Uh, and you do an just fast or by echo, you will see that that a lot of effusion around the heart. So it is clear that this is a case of pericardial effusion. So you will not jump and say, okay, let to drain this one. First, things to know that this is a lethal complication. Don't underestimate. You will feel that this is only a fusion. We will drain it. The patient is laughing, is hemodynamically stable. You should think it as a lethal complication. Now it is under control, but with low reserve patient, it may cause of death. But how frequent this fusion will you will see it in your life? See, this is a study for around 1,829 procedure on 1,150 or almost 50 patients. Only 136 they have clinically related pericardial effusion. That means they need intervention. While more, all of them, most of them, around 950, they have a fusion, but it's not clinically relevant. Clinically relevant, that means it need drainage, and so it's not a simple, but it is a variable complication. You will see it in your life. The point here, why this patient will develop a fusion? When actually in pediatric, we rarely those patients will develop pericardial effusion, and rarely they came with tamponade. Why? Because the surface area, and if you tackle the patient early in the pediatric without with the right side shunt, usually when you drain it and the shunt you resolve the drain, the chamber is not that huge, so the space which is not big, so the potential effusion is not developed. There is no clear reason why the effusion is developed. Could be due to autoimmune, we don't know. And those patients in pediatric, because they came in multiple redo cases, they will not have much pericardial effusion. And most of them, they will came in a patient who came in adult congenital, like patient with ASD, right side lesion, dilated RB, RA. Once you close the ASD, they will have a good space for accumulation. And if you look for your practice and you just searching in the centers here, for example, I work more than one center. You'll find one center they have so frequent, and other center they don't have it so frequent. So it is related to the surgical behavior mainly and cardiology behavior. Cardiology behavior in form of those, they don't cover the patient with the aerosis post op, they don't tackle the screening with the patient post op in regular way, and surgical procedure in form of they maybe the time of drain removal, or the time they didn't do more protective procedures. For example, we adapt ourselves that if we have a patient like an ASD, or the patient that has right side shunt, to open the right pleura and open the pericardium down, down, down near to the IVC, not to touch the IVC and injure the phrenic, rather than to down it widely. So the fusion will usually will shift it to the pleura, and it would end by no accumulation post-op. So the policy which is applied in each center make the frequency of this complication is different. That's why if you are working in the center, you should uh, tackle your KPI and look what is the cause, how I can improve it, and definitely this is a preventable complications. So now his patient has pericardial effusion, or let's drain it. Is it tamponade? So when you are presented this patient, this is the main question between me and you. Yeah, yes, this is a case of tamponade. So you should show me as I understand. So as a surgical doctor, that's I will ask by science, eco science of tamponade, and usually we are looking from our thinking that for the mitral valve and tricuspid valve, inflow is the main contributing that this patient will go for uh, inflow restriction, which means that this patient have impending tamponade. If changing of the mitral and tricuspid valve inflow from 30 and 60 in tricuspid valve is strong indication for us to say, okay, I will accept this patient to go for drainage. This is the main 4 points. I'm looking to hear it in the meeting that this patient have systolic collapse, diastolic collapse of RV, have IVC collapse more than 50%. So, okay, you diagnose this patient as a cardiac tamponade. Now we need to open it, to drain it. Who will drain it? You or me? Maybe me and you. Maybe you will do it and you will call me. Actually, who is the most risky person? Or is it the cardiologist, the surgeon, anesthetist, or maybe the patient himself? Patient physiology. Just to give you a stories from this. I work in and out. I have a lot of story to tell about this complications. I know a case with pericardial effusion went to pericarditis, and she was died by uh, pericarditis because the needle was hit the free wall of RV. The patient have a precardial collection. It was looks to be bloody, and the bloody drainage, and they keep the drainage. The patient was arrested because they are draining the RV. But the question here again, the RV is risky to when you are draining the patient. Yes, but the more risky is if you hit the RA, because the wall of RA cannot fill. If you think this is a bloody secret discharge drainage rather than a blood, and you will not feel it if you enter to the RA, which is more interior. Very difficult if you hit the LV and you feel that you cannot feel the LV, because the strong muscle of the LV will prevent your needle from movement, and you will see that your middle is wiggly and moving too much and strong, so you will feel you are hitting something versatile, so you will stop unless you hit the vein or the coronary artery. This is the dilemma. If you have this complication, stop that time and call surgeon, because it's a risky complication. Why? Sometimes if you just drain the heart, to put a needle in the heart, you injure the heart, the blood around the heart will stop. Yes, but if you have a fusion like this around the heart, it's a big space, so the whole blood of the heart will drain outside. Okay, I know also a surgeon. I was involved in the case, by the way. There is a surgeon, me, and I remember when in 2003 they asked us to drain a patient. I was dissecting subxiphoid, looking for the pericardial drainage effusion. There is no pericardial effusion. I called my senior. He came. I said, I can't assess where is the diaphragm. I can't see the diaphragm. He said immediately. He just extended the incision. He opened and put the drain, and the drain was in the organ. Patient died on the table. And I have know a case who was arrested because of anesthetist. Those patient just laying down, they give much of sedation, SVR is dropped, have low reserve, the patient with very low reserve, patient arrested, 30 minutes of CPR. And I know a patient who was a Glen, he has a fusion, and this patient just they drop it, they intubated on the table, and the patient was arrested because he's a Glen, there is no forward flow, and he has a huge effusion around the heart. So what I want to pass it as a message: don't underestimate these life-threatening events. This is a life-threatening event in very low threshold of for the patient. So you decide to drain it, and you found and you put a drain. That's all. You take all your measure, precautions. Bubble study before you insert on fluoroscope. You saw the wire inside. If everything is okay, and you drain, you get the blood, and you don't notice a blood or bloody effusion. You talk this a blood on 4 by 4. Oh, it looks like a bloody. Or you send it for EBG, and you compare it with the hemoglobin of the patient, and you said, okay, like a hemoglobin, this is most probably to be blood. This is not a blood drainage. So you go step by step and safe with taking all safety precaution, and you drain it. If you go like this and you think wisely, I think this the complication will be very, very, very minimum, and really you will face one of these cases which I saw it in my life. Next, you are in the ER, and they call you that they throw a patient in ER as a life-saving patient. Uh, now in this case, he's congested cyanotic. You do a rapid echo there, and you have a strong suspicion that this case is 2 days old with the total anomalous pulmonary venous drainage, or who could be in circulatory collapse on ventilator, and he is high in tropes with renal failure. But regardless of the presentation, keep it in your mind. Total anomalous is an absolute surgical case. This is the only true emergency we have in this field. She needs surgical repair. But the underlying physiology and dictate the time of the surgery. Maybe you should take patient immediately from AR to ICU to the OR, or you don't. Maybe you need just to stabilize the patient. But I will give you some points regarding the management of this patient. How the mortality of this region was improved from 80, 50 to 5 and 8%. This is a total anomalous. This is a supracardiac. All of us, we know it. Vertical vein, SVC to the RA. So there's a restriction here, or restriction for the whole pathway. And remember, this flow should go all this pathway back to the RA to the LA. So this tunnel is very long, and unless there is an obstructed lesion in the atrial, in the pulmonary vein, with time he will develop some restriction. So either he will develop immediately, or he will develop later on. That's why they recommend, if you have a non-obstructed, don't sleep. Don't sleep on that patient. Just keep it in your mind. Don't push him more than 3 months. He may develop restriction more than. They said 2 months, some extend to 3 months, but don't sleep on them. Just plan it. You will save the patient, because they have very extreme good outcome. This is the supracardiac. This is the cardiac. The cardiac is two type, either to drain the coronary sinus from the coronary cell to the RA, or they will drain directly to the RA. Or and this is a paracardic type, and this is a mixed type. This is a cartoon diagram how we do it. We open the vein, the confluent area, direct to the LA. We ligate the vertical vein, or these two veins they are draining to the RA, just buffering back to the LA, or they are draining to the coronary sinus. We unroof the coronary sinus back to the LA, and we cover the ASD. All these patients they will have the infracardiac, and from the back we suture this confluent to the LA. It's very nice cartoon, but this is technically is not an easy. This is an surgical anatomical descriptive of who we will see in OR. It's nice to show it to you. This is the right pulmonary vein. This is the left pulmonary vein. Drain, 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 drain to the coronary sinus. So it is a cardiac type. This is the pulmonary vein. This is the pulmonary vein. Drain to the right atrium. So also this is the cardiac type, but it's draining to the right atrium. This is the ventricular mass. This is the pulmonary. This is the aorta, innominate, left carotid, left subclavian. This is how see how big is the pulmonary. And look for this. This is a ascending vertical vein up to the innominate vein back to the SVC. If you turn this ventricular mass up, it will be like this. This is the vertical vein between the pulmonary artery and the bronchus, both. And so they are here the pulmonary device, where the once the patient is crying, this area of compression between both of them and pulmonary hypertension will be increased, and obstruction will be increased, and the circle will continue like this. This is an infracardiac type. Very nice. Both left and right, going vertically, long distance, down to the hepatoportal circulation, or even to the gastric, small drainage vessel to the drain to the gastric plexus, or could be direct to the IVC. This is infracardiac type. Keep it in your mind for these 2 days. Old baby is an surgical patient, and they will be presented in cyanosis or circulatory collapse, and they have a good prognosis if you manage it medically nicely pre-op or pre-surgical, but the definitive treatment is surgical. But because of improvement of the medical management, the outcome will become good. How to manage it medically to support the circulation and to treat the pulmonary hypertension in form of ventilation, low oxygen setting, high PEEP to decrease the pulmonary flow, correctal acidosis, give add inotropes if the patient in circulatory collapse. We don't use diuretic unless it is non-obstructive. Don't use diuresis unless the patient have non-obstructive total anomalous. The question here is the prostaglandin is indicated? Prostaglandin and pulmonary vasodilator, I mean nitric oxide, should be avoided in non-obstructed. But for the obstructed total anomalous with pulmonary hypertension like infracardiac type, if the patient in circulatory collapse, you may add prostaglandin just to keep the duct open and to maintain adequate systemic flow. But large patent ductus arteriosus may increase the degree of cyanosis. So remember, this is a case of total anomalous. So the transthoracic echo is enough. CT scan may be needed. Angio is rarely needed. And by TEE, transthoracic is enough to diagnose it. Is it obstructed or not? Where is the area of obstruction? The question will come here. Okay, this is the surgeon have the superior hand here. The medical management and the surgical procedure is the main rule. Any rule for the angio for this patient? Yes, they have in 3 areas, 2 pre and 1 post. Sometimes balloon arterial septostomy can be performed if they have a restricted interarterial communication and the surgery cannot be performed immediately. Like you are in rural an area far away from tertiary center, or you think this patient has intracranial hemorrhage, severe sepsis, you think it's just put it on bypass, he will not come back. Maybe you will give him a chance just to push him uh, for a couple of days till he become more stable. Also, either to open the restriction through the ASD, through the intraarterial septum, or to stent the pulmonary vein. Um, the stenting usually will develop because the obstruction is more common in infracardiac type. Post-op also, we may need this to recoil or to closing the vertical vein. See, this is the cut of the patient with the with the supracardiac. This is the vertical vein. This is the area where they stent the anastomosis. This is the stent, and they fix the stent there. So now it was obstructed. They converted non-obstructed for as a primary procedure, self-lay for definitive procedure. But sometimes this vertical vein we did not close it post-op because this patient will have pulmonary hypertension and we keep it for a venting of the right side during a crisis. If the patient past the critical time, we discharge the patient and bringing back again for the once the BA pressure is dropped to omit the left to right shunt by coiling the vertical vein. So yes, cat still they have a strong rule in total anomalous. This is a good paper. Through this presentation, I will throw a landmarks paper. I think you should read it. Any rule for the ECMO in our situation? Yes, we can put ECMO pre-op if the diagnosis is not confirmed. It will add a medical management just to support the patient treating the hypoxia and acidosis, or the bridging till the patient is more stable. Post-op, you may keep the patient on an ECMO if the patient cannot come off bypass, or this patient still have residual pulmonary hypertension, and those patients usually they have residual pulmonary hypertension. I need support post-op. This is the diagram showing how you will deal with the patient. So you will receive total anomalous. You will diagnose is obstructed or not. If it is obstructed, you will go for urgent repair by operation. Then you classify cardiac infra on sobra. Then you will go and according to and you correct it surgically. If it is not, so you will go in elective repair in infancy. And I told you and just emphasize the same. Don't sleep on the patient with total anomalous even they are not obstructed. Another life-saving events you may see it in your life is when you receive a patient, a neonate or an infant less than 6 weeks with shock or profound cyanosis. This two presentation is the main presentation of ductal dependent lesions. That means that patient either has left side dependent lesion or right side dependent lesion. And because of obstruction of those patients and duct closure, that patient will be presented either on profile shock because of LVOT, left side obstructed lesion, like coarctation, interrupted aortic arch, or hypoplastic left heart syndrome, or may be presented with cyanosis as a patient who is pulmonary circulation depending on the duct, like a case of TOF or tricuspid atresia, pulmonary atresia. So those patients will be presented as a cardiac cyanosis or with low cardiac output. If the cyanosis of those patients will be presented because of pulmonary atresia, tricuspid or tracheal outflow, or due to mixing. There's there's a BDA. BDA is still open, but still he has poor oxygenation due to mixing and could be due to total anomalous pulmonary vein drainage I talked about before. Or he maybe have obstructive lesion left side, like as I said, interrupted aortic arch coarctation, hypoplastic left heart syndrome, or severe aortic stenosis. So if you have a patient with there is no obstruction, but you need to improve the mixing of this patient, you need to do atrial septostomy. This is the list of most common indication of balloon atrial septostomy. Either the patient has transposition, you need to open the atrial septum, or total anomalous, as I said, some indication. Tricuspid atresia with the restriction, hypoplastic left heart syndrome with the restriction, pulmonary atresia with intact ventricular septum with the restriction, or with have pulmonary hypertension as a venting for the right side system. Failing point out, we need to vent the circulation also, or sometimes you need it. I keep it in your mind that sometimes in ECMO when you do a VA ECMO and the patient have LV dysfunction, you may need atrial septostomy to vent the left system. If the patient is not in neonate and came in infant, also he will maybe presented with hypercyanotic spells, same presentation, but just 3 4 months later, or he presented with signs of heart failure. Heart failure that means the pressure is dropped, and he start to have signs of left to to right shunt because of BDA or VSCD of AB window or truncus arteriosus. And sometimes he start to have myocardial dysfunction and he has a heart failure. All of these lesions will be presented as later on as life threatening events, usually in infancy. So let's to go and to talk about ductal dependent lesions, left side and right side lesions. This is the last and updated paper which was published just last September. This is the panel of experience from the congenital cardiac surgeon, cardiologist, intensivist, all of them, they create a question. Then they make what we call the BICO. BICO is the patient population intervention comparison control outcome framework. They make a framework. They bring questions. Then they arrange a guideline and they develop this guideline. They develop their recommendation with level of evidence. And their recommendation by the paper that left side lesion surgeons still have higher hands, superior hands, and surgery remains the standard of care of management of the isolated coarctation in the neonatal infants. What is the other recommendation also? The other recommendation on this guideline that the patient with the risk factor for surgery, he can't go for surgery. We can keep this patient on medical management before intervention, and this is a reasonable. That's mean is like around is a class 2A for those stable on prostaglandin. So you will the patient is stable, you'll take this patient to the surgery. The patient is not stable, you may give it on medical management. If he's stable on prostaglandin, when you are going to intervene, the threshold for intervention is unclear, depend on the local experience. Once the patient is, you think is reasonably stable, you will take the patient for the surgery. What is the weight? They 2.5 is the reasonable cut weight to take the patient for surgery. Thoracotomy is indicated there is no arch hypoplasia. Sternotomy for arch hypoplasia. This is a class 2A, this is a class 2A. But sternotomy may be considered in the presence of bovine arch class 2B. Uh, to bridge the knowledge between you and me and us, between surgeon and cardiologist, we learn and they keep teaching us the rule of thumb in assessing of hypoplasia and how they will be amenable for repair surgically and how significant will be the residual stenosis. We depend on the rule of 60, 50, 40 rather than the weight and plus 1 mm. And we said this is ascending aorta. If it is the proximal less than 60% is hypoplastic, less than 50% is hypoplastic, less than 40% is hypoplastic. And fortunately, this lesion we saw it a lot in King Fahd Medical City. And if it is like this, with this good distribution of the proximal and distal, at least you have clear decision. But the problem when you have a bovine arch, a bovine trunk, with very long distal one, with very short, almost there is no proximal arch. Here, the all the surgical technique will be changed. Any cat intervention or cat-based intervention can be used on those patients with coarctation. Actually, the balloon intervention on those patients, they have very limited rules because they saw it showed that they have early recurrence and they will develop aneurysmal formation plus the access related injury. Just take this number and remember this number 60 and 90. Keep it in your mind. 60% require subsequent surgical repair after ballooning. 60%. And 30% will develop sacral aneurysm. While those with surgical repair, 80% will develop coarctation, post-balloon dilatation. That's mean for balloon dilatation. I mean that if you do coarctation, 80%, let's just say 20%, they will need a ballooning, which are responding for ballooning. And no patient will develop the aneurysm. There was an old series of aneurysm development when they do a batch with dacron batches was very bad stiff batch. But the balloon angioplasty in critical ill neonate who are poor surgical candidates because of severe left ventricular dysfunction, intercurrent illness, they can they this those group of the patient they can push through evaluation, inter-surgical correction can be safely undertaken. And the recurrent, the balloon will be the treatment of the choice and the standard of the choice when you have a recurrent coarctation. When you have a recurrent coarctation, 90% of them will respond to for ballooning, while in the primary, 60% will they require another surgical repair. So it is the standard for a recurrent coarctation. So it is a standard for recurrent native coarctation. Uh, and 60% only the incidence of restenosis, which require another intervention. So superior hand will be for the surgery for the native coarctation. Balloon angioplasty is the superior for recoarctation. This is the message. So this left side obstructed lesion, we talk about coarctation. Also, we have other like interrupted aortic arch. We have around left heart syndrome. This is very, very, very good paper. Was summarized the treatment of uh, three pathway of treatment of left hypoplastic heart. They compare the using of hybrid with Norwood RV2BA conduit with Norwood and BT shunt. And they found that the Norwood RVBA conduit is superior with 76% survival. That's why maybe because both of them, the coronary perfusion have the same physiology. This one, the coronary perfusion is separated from pulmonary perfusion. While in case of hybrid and Norwood BT shunt, the coronary perfusion are have share the same. But it showed that the best survival it came with RV BA conduit. Although the hybrid are not lower than the BT shunt in stage one Norwood. And maybe they used to improve the survival in the neonate. But which neonate? They are not improve the survival in general. They improve the survival in the neonate with low birth weight. When we are talking about low birth weight, they are talking about 1.5 to 2.5, where you are hesitating to take this patient for Norwood. So you can push them through the hybrid, and 24% of them with the hybrid will come back for you. 25, almost 25% of them will be converted in 2 3 weeks to Norwood petition, or just breathing them for 1 month, then taking back again for Norwood. Look, this is very nice to compare. What's the pathway? What's the decision between the surgeon and the cardiologist around? Came from 20 institute, 564 patient. This is what we said is an hybrid. You put a stent in the BDA, and the surgeon will band both pulmonary arteries. So we open in the OR. We put a band here. Put a bear string on the pulmonary. The cardiologist will scrub and through his sheath. He push the BDA down to the through the BDA stent through the BDA, and the patient will survive this time. Later on, some they adapt to to do ASD septostomy later on after before discharge once the LA a little bit big so they can enlarge the ASD. So it is an alternative intermediate step with low birth weight. So yes, surgery is superior on that side, but we can't move without help of the intervention cardiologist. Again, I will show you BA band, BDS stent, creation of adequate ASD. This is the stent, this is the band, this is the band, this is the band, and this is the stent. Then later on, the patient will come directly if he will not be converted to Norwood and will stay. We win to push this patient till that second stage. The patient will come, we remove the stent, and we reconstruct the artery, and the coronary artery will resuture it to the pulmonary route as aortic route, as- and we finish the gland. So the patient went only for one surgical step. Please to say that the band is not considered as a surgical step. So we shift the surgical risk of on major open heart to an older age. And definitely, this is a helpful event. In our KFMC, we adapt another technique. I think various case report it will be once we have we collect the data of this patient. Let's to say this is a KFMC procedure, Tamim procedure. It was very nice idea to be honest. See, this patient cannot be operated because we don't have a acceptance for neurode in our center. The our cardiac intensivist and interventionist, they put the BD stent here, and they put two, this one and this one, two flow restrictors. So instead, even the surgeon to come and to put a band, this flow restrictor will work as a band. So totally will be a cath lab rather than surgical cath lab in work. This is the video we showed how it works. This is a new technique. Maybe if it not only it will be not allowing if we show a good result, not will be only in KFMC or even outside. So let's just say that the surgeon had a superior hand in left side lesion, but the cardiologist they are the one who have the superior hands in the right side lesion. The BD stent in the unit now become a reasonable alternative to systemic BT shunt for initial palliation of the complex heart disease, but in experienced hands. Because I'm working in centers when even with the uh, maybe the BT shunt is the standard rather than BD stent is the standard. But if you have a good experience and really the duct stent seem more feasible in 90 to 80%. They show low mortality, higher rate of yes, they have higher rate of reintervention and shorter hospital stay. And regarding the access, with the help of the surgeon, they can get carotid access or they can do it through the axillary approach. This is three important papers you should look for it. And this is the meta-analysis. When you read there is a meta-analysis researcher review, just catch it in your hands because rarely you will get it in there is no randomized control study in our field. So when we have a meta-analysis, we catch it because it's the strongest evidence we have. This is a total of 1,094 paper from eight studies. They conclude that the stent still have lower mortality. Yes, there is higher rate of pre-intervention, but they have lower hospital stay. So if you compare between the shunt and the stent in right side lesion, which is the best? Or let's to say what is the advantage and disadvantages of each of them. BD stents appear to be not inferior and maybe superior to in the palliation. It improves the mortality from it is 6.6 in stent, it is 10 in surgical patients, short intensive care unit, short hospital stay, lower rate of ECMO, more symmetrical pulmonary growth. This is very important point to be mentioned. If the stent was put nicely or fixed nicely on the BDA, the flow will BDA will distribute it to both of them symmetrically. That's why there is a symmetrical growth. Rather than to put a BT shunt on one side, they feel that the flow will go in both side and in the right side more than the left side. That's why you have asymmetrical growth of the uh, pulmonary circulation. Does it affect on the second stage of the Glenn? Not proved. There is acute complication is serious. For example, if you have a stent and the stent was caused pulmonary gelling of the one of the branches or embolization or thrombosis or spasm, this is very important complications. But uh, usually, if you have a good backup, I think the best interest of the patient is to go with the stent rather than TPT shot. Late complications could happen also with the stent, like pulmonary overflow if the stent was directed toward one of them, pulmonary hypertension, or let's to say less pulmonary flow with time. But this is, I don't know, this is a bad things or a good things because they consider it an adjustable shunt because this shunt will develop intimal proliferation and the flow will go down low and low and low. So you'll go back again and dilate this shunt. So they will increase the flow again. So as you adjusted the shunt, this is good and bad things because also when you inflate the stent, a lot of debris will came from that, and they said this is a drawback of the also of the inflation, and the inflation is not an easy procedure for the BT shunt. Still, more have uh, is a choice, but they found that most of those in the paper of meta-analysis, they said they have higher mortality. But this higher mortality, if you look deep in subgroup, you'll find that surgical shunt was more in the single ventricular physiology with single source pulmonary blood flow, which is usually the those patients they're not in single source pulmonary blood flow because of the risk of spasm and death on the table. That's why we said when you are going to stent the BDA with pulmonary atresia, you should have a surgical backup, and OR is free to you in case you need any intervention. Here they said, no, not more than this. Even the ECMO should be standby because you don't have time to go on cardiopulmonary bypass. You have a time to go on ECMO, then you shift the patient to bypass and you put a shunt. So surgical backup on single source pulmonary flow is important. No risk. There is no risk here for getting pulmonary branches, but still it's a surgical case. And if you put it on the stump of MBA, you expect you have a symmetrical flow. So I think if you read these 2 points, at least you are oriented about the left and the right side lesions. Well, and the most important step, we will discuss it in the meeting. One im- one life-threatening complication you may see it in your life is a patient who's coming to the a neonate or infant with complete heart block. So this is a case where passively acquired autoimmune disease. The mother will maybe asymptomatic, and a patient may be symptomatic, and you throw it in ER, so it's easy to be diagnosed and indication for pacemaker. But the patient may be asymptomatic if he has profound bradycardia of LV dysfunction or bronchioti interval, and they are very high mortality unless you basing them, and they have their mortality up to 60%. The more important risk factor for them is small birth weight. That's why if they are coming, I need to base them. We base them temporarily. We open subxiphoid, we put a temporary basing wire, and keep the patient till his weight is increasing. The 55 beat per minute is a cut point for asymptomatic patient for intervene. Just look, this is the battery. Again, I hear it from one of our fellows with the difference battery and the pacemaker. This is the battery. This is the lead. So there is a lead. This is a battery. So just imagine the size of the battery, how big it is. So once you have a small baby like this with complete heart block, we plan it to put temporary basing wire. That's I showed it before, and keep the patient till his weight is higher little bit. Now new adventure that this is the new battery. This new battery around the volume of 6 gram, the weight around 13 gram, the diameter around 3 by 3. This is the smallest one we have now in our center. New device it came in the market, inshallah, what we call the Micra. This one you remember the bullet type, you use it in the adult. They try to put it as epicardial under investigations. So you need epicardial basing for neonatal infant. But if the patient is an older, and the question between surgeon and the cardiologist, EPIC, I mean, is this patient for transvenous or endocardial or epicardial basing? The adaptation of the policy adaptation from center to center is different. Some of them they keep it if the patient above than 2 years, they will push for endocardial. Some they go more youngest. Some they delay to 5, 8 years. Some prefer to be in 30 kg. Some they think that 10 kg is enough. Endocardial is not without complication, and epicardial are also not without complication. But the trend seems to be toward more epicardial leads. Yes, there is an high initial and long-term capture threshold will develop with time, but the new developing steroid eluting tips appear to be equivalent to endocardial leads. and those threshold will not develop so fast. Plus, when you do endocardial release in a growing child, it will be mismatched with the somatic growth. So still epicardial is best. With that, you have a vascular injury, you have a vascular trauma, and also the extraction if this for those leads have a lot of potential fatal complications. And you should think about longevity of these leads. Just imagine that this lease will start from 30, 40 years. So he will end by no veins. All of them will be thrombosed. Lastly, or before the last, I think, sometimes you have a devices that was uh, embolized, and you need to retrieve this device. The points here between the cardiologist and the surgeon, uh, that this device is a risky, it can embolize anywhere. I came across a case in the missions. By the way, those retrieving, usually we saw it in the missions too much. That is a phenomena. The point before that, for that, because they want to do a lot of cases and they feel that, okay, this is an ASD, we count one case and we do the device, the patient will be out of the service, we can put another patient tomorrow, all of this. So the threshold, they cross the threshold. Actually, the threshold, you should have at least 5 mm REM so they can fix it. Don't oversight the device. This is the main important point. I came across a case when they put it one day before we leave, and we went to an emergency for the patient. The device was in the arch. I know from Dr. Faradi one case the device was in the descending aorta. Last missions, I retrieved two devices, one from the pulmonary artery right and one from the MBA. So the message here: don't cross the threshold, and whatever you put in the patient is a risky. So keep always the margin of safety. Trauma is another area where we, all of us, presented together to save this patient. And once we are cooperating together to do one work, the outcome will be amazing. This is the patient who has uh, a thorn transfixing the heart from the chest down to the descending. This is descending aorta, so it's moving around the descending aorta from free wall of the RV to the interventricular septum to the LV to the posterior of the LV. And our team decide to take this patient direct after CT to go on femoral bypass, and we exclude esophageal injury, we have TE inside, then we assess the any other injury, then we retrieve it and we repair it, retrieve it, we repair it. Our cardiac Dr. Umar was there, Dr. Cardiac interventions, that if there is a VSD here, we will go to close it by device. That's why this is the point that I need to mention it, that teamwork to save a patient. Actually, this patient was surviving and we published this paper recently. Rarely patient will be presented as a case of Alcava. The point would mention here to the Alcava that this patient will be missed from diagnosis rather than by intervention. It's a pure surgical intervention. They may be presented with any symptoms related to heart failure or not in heart failure. They even will have GI symptoms and different type of illness, and lastly, this patient will have seems to have myocardial dysfunction, which is actually an Alcava, and early recognition of this patient, sent him to the surgeon, and by good result rather than to develop poor myocardial dysfunction. The message from this lecture, I know it is long, that cardiac emergency is challenging and early intervention is crucial, and the effective work is crucial for success. And there is no one is superior to the other. No, not the surgeon is not superior. The cardiologist is not the superior. It's the cooperation of both of us to make an effective teamwork. Thank you.
شكرا دكتور سامي جزاك الله خير. Now I will try to allow people to be unmuting themselves if they have any questions. Meanwhile, I just want to mention that The hybrid stage one is we do it, yes, in first time in King Fahd Medical City, but it is done in several places with the use of the flow regulator. Dr. Junaid have raised his hand, so he can unmute himself and can ask the question. Dr. Junaid, تفضل دكتور.
السلام عليكم.
عليكم
جزاك الله خير
السلام.
دكتور سامي، دكتور عمر، على such activity. يعني بعد غياب قصير جزاكم الله خير عدتم وأبهجتمونا بهذه الاكتيفيتي حفظكم الله. سؤالي two questions only. The first one about how frequent is the pericardial effusion post-pacing wire removal in the pediatric cardiac surgery? And are there any rule about it for the timing of pacing wire removal in this incidence or not? Second question, in order to avoid asymmetrical growth in the PT shunt, why we don't make the shunt to the central MBA the standard one? Anything making this not the standard?
لا 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 لسه الترابيزه في بابا والله شيلها حديقه شيلها حديقه
الو.
Yeah.